another exclusive conversation at ET Health World, we have the privilege of speaking with Professor Anurag Agrawal, Dean of Biosciences and Health Research at Ashoka University, a distinguished physician, scientist, and former director of Institute of Genomics and Integrative Biology, IGIB. Professor Agrawal is at the forefront of innovation in genomics, artificial intelligence, and respiratory health. In this interview, we explore his journey, insights on the future of biosciences, and his vision for shaping the next generation of healthcare leaders. So, going to Dr. Agarwal here. Doctor, the first question I would like to ask you is, you have been a strong voice in genomics-led public health, which all of us here know. So how can India better integrate genomics into the routine healthcare, especially for NCDs like cancer or cardiovascular conditions? I think genomics itself has got a good limelight after the pandemic, I should say. Over to you, Doctor.
If we think about genomics, I mean, there are a few very obvious applications where even India is doing quite well. For example, for children with undiagnosed diseases, rare genetic diseases starting near birth, we already had at my former institute, IGIB, many other places in the country, excellent sequencing programs and capacity to do next generation sequencing. And I think that's an area we have done well. Now, the same capacity can be used for other things as well. We now know that in a variety of cancers, which mutation you have completely determines the type of therapy you would respond to. In fact, some of these new generation tyrosine kinase inhibitors, which have minimal toxicity in really fatal diseases like lung cancer, for the right mutation, can make the tumor just melt away. And the same thing is seen in a variety of others. Again, I would say that in the private sector, in particular, and top and tertiary government sectors, this kind of testing has become available. Now, the challenge is always price, because in rare genetic disease diagnostics, strong research programs that got built, that while doing the research were also offering services, and these were small in number. But on the non-communicable disease, particularly cancer side, while private companies have come in very nicely, for example, you might have heard of Karkinos. Karkinos is offering world-class diagnostics. Strand. Recently, both Karkinos and Strand have been acquired by Reliance. So Reliance has clearly decided that genomics in areas like cancer is going to go mainstream. So I think these cost efficiencies will come when big companies like Reliance, the way that perhaps Geo transformed mobile data, transform the availability of genomics to everyone. I think it's fundamentally a price question, not a competency question at all. Then comes the last part, which is genomics for public health. Now, genomics for public health has no single payer. No one person benefits from it. Genomics for public health will only come with the government as a payer. And that will come for areas like genomic surveillance of pathogens. And I'm very glad to say that INSACOG still exists. New surveillance mechanisms are being created. National Disease Modeling Consortium has been created at Koita Center for Digital Health at IIT Bombay. Even the Koita Center for Digital Health at Ashoka is contributing to such work. And genomics is integral to it. And antimicrobial resistance, for example, is a great area for these applications. Again, a variety of institutes, including Ashoka, is working with ICMR to work with this. Recently, the National Center for Disease Control, we organized a workshop for genomic training. So here, I think the uptake will be slow and steady because private payers have no great incentive to get involved and will fundamentally depend on government and government institutions.
How can we now use that momentum to build a more robust pathogen surveillance infrastructure across India? Because that is also more important, like the other segments you had mentioned. If you can give us more insights on that. And also when you said private healthcare is coming into this space, so it will not hinder the affordability, right? Or rather it's going to help, if you can hint that as well.
Let me take the second question first, because it's a continuation of the previous. Take mobile data, take mobile calling costs. We had MTNL and BSNL and VSNL well before the private players came. costs are actually lower today than they used to be. I don't think we should assume that the private players will drive the costs up. At least in the case of Reliance and Jio, we have seen they can also drive prices down. And perhaps that is their way of operating anyway. So I personally look forward to seeing what happens. I'm not wary of it. I personally think the costs will come down. Should only one dominant player be there? That's a separate question altogether. I believe that if that one player shows that there is a market, many others will automatically come along, and competition is healthy in India. So hopefully we will do that. Now coming to the other question of genomic surveillance for pathogens, let's do a thought experiment. Let's imagine that something like SARS-CoV-2 has started for the first time in some corner of India. Will we come to know? Will we not come to know? The only part that we will come to know is primarily going to be that people are falling sick at a high frequency at certain places, and that hopefully will not have to be reported by newspapers before we get to know. The government, particularly what the National Center for Disease Control, has a branch that does surveillance. And IHIP, for example, has data that is collected from across the country. It is more and more digital now. And this program called the Integrated Disease Surveillance Program called IDSP, using the software called IHIP, the portal, now even allows citizens to upload data. So my feeling is that we have got to the point that if the system is well used, we may be able to find out the clinical part of it. But is it sufficiently used right now that we would actually find it? Perhaps not. It'll require some more work, but we are further along than we were earlier. Now we have a portal, we have ability for citizens to access it. We have multiple ways to add data, but ultimately, states and center must seamlessly share data. And health being ultimately a state subject, but regulated at a central level, creates problems, I think, which need to be solved. Then comes the second part. Using genomic surveillance, would we be able to know that a new pathogen had come? This is more difficult. Most surveillance occurs for things you already know exist and can efficiently screen for. Screening for something brand new is tough. It is expensive. It requires shotgun genomic sequencing. It requires improvement in technologies. It requires improvement in pipelines. There are a few high-quality research places in India capable of doing it. TIGS is probably the best example from Bangalore. We are trying something similar at Ashoka. But to be honest, a lot of work, a lot of research needs to be done before we say that's going to occur. Even in the case of SARS-CoV-2 in China, it is only after people realize that people are falling sick, then you took isolates from those people, then you sequence those things. They found SARS-CoV-2. That we can also do in India today without any problem whatsoever. But the idea of just from the genomic data in wastewater, in things like this, figuring out something is new, that will require substantially more research, but that will occur. I have no doubt that it's a matter of time and investments.
So, while we talk about genomic sequencing, we have touched upon that. I would want to go to the precision medicine. Like, how do you see? Because, like, you've spoken about the genomic sequencing and how it has the challenges and how we have to overcome. But now, cancer burden increasing year on year. Thanks, we are detecting a lot. But how do you see the future of precision medicine evolving in India? What are the practical steps makes it accessible and not just limited to the elite institutions or urban hospitals? Because I'm not seeing precision medicine penetrating into the tier 1 or tier 2 hospitals as well. Maybe the cost factor is there, but treatment is needed for everybody, right? So if you can.
So let me expand the definition of precision medicine to any kind of advice to an individual that is not one size fits all and is tailored to their health, right? In this, if you imagine anybody wearing a continuous glucose monitor, maintaining a food diary, seeing what type of food leads to a spike in sugar and what type of food doesn't. You will find that there will be people who can eat an ice cream without getting a spike in sugar, but their sugar will immediately spike with rice. And if those people are already diabetic, and I give them advice based on their CGM and their daily diary, it is already precision medicine. If I were to make it automated, with mobile phones receiving all their data, taking snapshot of their plates, automatically breaking down the foods, and automatically giving them the advice with some AI. This is health AI, digital health, and precision health all rolled in. If I take someone who is not diabetic, this is precision wellness. If I make somebody wear an Apple Watch or any other watch, not to advertise Apple for free on your show, and I were to look at their exercise patterns and their VO2 max, their exercise capacity, and advise them accordingly regarding the need to do more exercise or less to improve their fitness, that's precision wellness. So my feeling is the low-hanging fruit is here. The upper end of precision medicine, that is, a person comes with cancer, you choose which anti-cancer drug to give, is kind of predicated on the availability of those drugs. But many of those drugs for which you do the precision medicine testing aren't necessarily available in India. So it creates that catch-22 situation that there is no traction for precision medicine, because even after it, the advice does not necessarily change by very much. So I would focus on getting the modern physician used to the idea that beyond clinical exam and thinking of the doctor, data-driven, digital health-driven precision advice can be given starting from wellness all the way up to non-communicable diseases like diabetes is perhaps a better way. Right now, we have 2 grants in which we are working to diagnose asthma exacerbations even before they occur, stepping up treatment so that the exacerbation never occurs, and then another grant for COPD. So that too is precision health. But these are easier in some ways than things in which we are deciding which drug to give, because many of those cutting edge drugs aren't easily available.
So this is about the impact of the withdrawal of animal testing in the US for drug development. So what would be the impact? Will it be a positive step for research on monoclonal and antibodies and other biologics? How do you see this?
It's a very interesting direction. Part of it comes from the frustration that the animal models we rely upon for drug discovery are not reliable predictors of how it functions in humans. For examples, I don't remember who it was that said, if mice were men, we would have cured cancer 100 times over by now. Right? I mean, starting from the story of angiostatin, so many times we have found drugs that are like miracle workers for cancer in mice and turn out to be average to less than average in humans. But the second frustration is it can become a waste of time. We might even be losing valuable drugs that might work in humans that simply are not tuned to work in mice. So I think an appropriate regulatory system would not remove animal research, but would allow animal proxy testing in a way when you get to need emergency stuff out. And I think the West is less worried about it because the West has easy ways of doing human trial. West can even do pathogen exposure experiments on humans directly. The reason is they can pay people to participate. It is assumed in their system that nobody is so poor that they would have to sell a kidney to live, allow themselves to be exposed to pathogens to get the next meal. So abuse of participants in trials, which is officially called voluntary, but is actually involuntary because of circumstances, they're not worried about it. In India, we have to worry about these things. And because we have to worry about these things, we don't allow people to be paid to participate in trials. But if you don't allow people to participate and pay to participate in trials, tell me how easy it is to going to get a person to get a pathogen challenge done to themselves. Probably not. So, which means we're going to have to use an animal model for that pathogen challenge. So I don't see any time that is disappearing from us. There might be a variety of other reasons behind this thinking that I'm not aware of. But to the top of my mind, these two, three things come immediately. A, in India, we cannot remove the animal because we can't go directly to human for dangerous things, where other people use money to get them to participate. And two, there are some utility to animal data even today. The closer you can get to a human animal, like monkey studies, the easier it is. Some of these things are political. Once upon a time, Ames Animal House used to have lots of monkeys for research. Then there is a very famous example of when people came, they felt bad, and they decided to let the monkeys out. So they thought it was wrong. There are certain overtones to it that get mixed up with religion. These are just challenges we have to face.
Going on, I would want to ask about one of the challenges in the Indian bioscience is translating lab findings into real world solution. We do that, but where is the real world solution? How do we get there? So, what systematic changes are needed to ensure more translational outcomes?
So, it's called the valley of death, from lab to actual health outcome things. So, why is there a valley of death? Sometimes people aren't willing. Sometimes the terrain is hostile. And sometimes, there is many deceptive bridges that drop you in when you're in the middle. So the first part about people not being willing, there are only two approaches. One is incentivization. They feel it is worth pursuing further. You make promotions and things like this contingent on doing things and having impact as opposed to simply publishing more papers. Or number two, you develop a culture. You might remember the famous poem, right? Charge of the Light Brigade. On to the valley of death, wrote the 600, right? So, irrespective of thinking what's going to occur, the culture of the place is that unless you're trying to make a difference, you are not seen as a successful person. You're not seen as an acceptable person. That culture shift would also come. And in a way, the two are linked. If your promotions, your recognitions are linked more to impact than to publications, then this culture will come. And the second would truly come from passion, which could come all the way from recruitment. Recruit people who are passionate about making a difference. Don't get into exam mode systems. These are easy for me to say, hard to practice at a scale of a country like ours. But if you want solutions, you have to bring in passionate people willing to do it. Then you have to make it easy for them. If going into the field trying to translate will require substantial extra hurdles for no benefits, people won't do it. So after your incentives are in place, at least you remove the disincentives, make it easier. And last, be aware of hands that you put out saying that this will make your life easy, this scheme that actually don't work. So create schemes that work and work with incubators, fund incubators, and the government has done a very good job with the Atal scheme. Do more of it, and I think that's the way forward.
So, add-on question to this, as you said, like there should be a culture shift and recruit passionate people rather than the exam board. So, how can we bridge the gap between India's world-class research talent and its limited biotech product pipeline? And what role should academia and industry partnership play? Because you're from an academic background, so what role you will be like playing or you're playing, and how do you bridge this gap?
It's a great question, and I'll be honest in my answer. Catch them young. See, if you catch them very late, they would anyway have removed their choices. Research is their career by the virtue of the path they have taken. Whether they have passion or they don't have passion, that's what they're going to do. And everybody will claim passion at that point in time. I personally think a strong undergraduate research program, bringing in people before they become a bit jaded, about the system, and then continuing to mentor them and refining their research abilities and their passion in the journey that ends with a PhD. And of course, nothing ever ends, but that journey should start with passion from undergrads, with skilling and training right at that end. One of my key desires at Ashoka is to build a world-class undergraduate research program, and we are doing that actually in an innovation center that is connected physically by walkways to the Trivedi School of Biosciences, so that people can move back and forth. Young people during their undergrad can do world-class research, get exposed to cutting-edge equipment. I mean, it's an experiment. I have no idea how it's going to go. But my own feeling is that every person I knew who was super passionate about research from their undergrad times looked for opportunities and got opportunities, went on to make some degree of a small difference. My small sample size, my feeling is this will work.
Fine. So, good to know about that. We need to encourage them while they are young, as you said. So,
Oh, one more thing before
yeah,
we have
please.
also started the Lodha Young Genius program here.
Okay.
Now, this will sound contrary to my own journey. I think the problem of everybody trying to become a doctor or an engineer by giving NEET or JEE
Yeah.
is ruining the appetite for research and inquisitiveness. So we fly in young students to Ashoka, class 9. They live here for a month. We expose them to some of the best minds in the world. Paul Nurse is coming, a Nobel laureate, very soon. There'll be more. This is done by the Lodha group. So Abhinav Lodha is personally oversees this. It's called the Lodha Young Genius Program. These kids are super smart. And if they get into their mind that coming to a liberal arts and science university, not necessarily us, to pursue science and do research for discovery is a better path in life than going straight for professional education. We will do much better with these things in the future.
I would also ask about, wanted to ask about what are the some policy shifts needed to make India a global hub for bioscience innovation? Um, I think there are a lot of things are happening in that space. How do we drive investment and commercial scalability in the life sciences sector? Though there is a lot of innovation when it comes for investment and commercial scalability, there's a catch, maybe. Correct me if I'm wrong. So, if you can just explain it to us about that.
I think India has been making investments and getting outputs in the bioeconomy sector. In fact, DBT's most recent policy, E3, is all about a bioeconomy and production. The challenge I see in getting people to invest, and this is from personal conversations, is they are not convinced at the time they are telling us the problem that we will provide them the solution. Many drug companies in India still send all their difficult testing to foreign universities. And we have also been backward in giving people timely and responsible results on questions given to us. People who have often given money to academia to do work on a problem of interest to industry have found that that work simply became a PhD topic in the lab without enough attention to what was demand of the industry that gave the problem. So we need to solve these problems. I mean, I'll not say the industry is completely blameless in being willing to support academia, but academia is also not blameless in taking money from industry and working in a focused manner to solve the problems. Those institutions that have done it have gone on to build nice, lasting relationships with industry. CSR labs like NCL, IICT had brilliant relationships with pharma. They wanted a molecule built, IICT would build it for them, or NCL. So these collaborations need to become stronger. Policies, of course, are changing in that direction. And the reward system for the researcher needs to be better aligned to these outputs.
So, when we talk about the like one more question on research, the National Research Foundation aims to fund and boost scientific research. But what should be its top priorities to drive impact in life sciences? Like, if you can give some examples or some.
My personal belief is that ANRF, should primarily be a mechanism of funding all good research at university level. Trying to think too much about where impact will come from is probably not very useful beyond funding the best passionate people who want to do research and giving them the opportunity to do it. Because, ultimately it's about creating better universities, then better students, better manpower. It's not the same as a CSIR lab or a DBT bricks lab, which have a very precise mission. Just good research at scale and with involvement of students, I think is a sufficiently good motto for ANRF from my point of view. If they just do this and do this well, I think India will be a better place. Impact will come automatically without planning for it.
Your leadership at Ashoka University, how are you preparing students to be both scientifically rigorous and socially aware? You had mentioned few pointers earlier, also the new initiatives you want to bring in and what would be your focus. So, why is an interdisciplinary approach is critical in modern biosciences? If you can touch upon that as well, Doctor.
To me, the future of biology is entirely interdisciplinary. I these days go around giving talks on AI as the new language of biology. I personally believe that every person studying biology today should become reasonably familiar with computation. We are planning an interdisciplinary major degree. It's almost done between computer science and biology. Next year, you should see us be launching potentially a major in health sciences and a minor in digital health. And health is naturally interdisciplinary between economics and society and social sciences and natural sciences. Everything is there. We believe that health needs more such people. Biology needs more such people. We are too small a university by numbers to make any difference to the real numbers India requires. But we are a good place to experiment and see which model might work. As you know, in our model, in our first year, everybody does only foundations. I'm just coming back from a foundation of science course, teaching principles of science through health, in which I was teaching the history of health. I was teaching about Dr. Mesmer, the idea of animal magnetism, and how, King Louis ordered Benjamin Franklin and a committee to see whether it was real. And they came up with the first blinded trial, right? And that's where evidence came from. So my belief is if students get exposed to ways to think, they get exposed to a variety of subjects, they get opportunities to do research, they will come up in a better way, and that'll be good. And that's really all the vision we have. Most things are optional for students. They don't have to take my course. They could take on a different principles of science course. Very few things are compulsory, but we believe you throw enough good choices at people, they'll take some of them.
What are your thoughts on how India can better nurture young talent in life sciences from school to postdoc? I think you've touched it, but still, if we can specify. And how do we prevent brain drain and build a robust research workforce?
The most important thing to reducing India's brain drain is happening currently outside India. So I would argue that many things happening in favored destinations of Indians traditionally will make them feel increasingly non-welcome. And that alone should increase the pool of people who are staying back. But the question is, if we had double the people currently staying back, do we have good training mechanisms for all of them? And the short version is we don't. If we wanted to treat biology people in AI, we have to recognize that many of these people may have tried for medicine in the past, may have given up maths in class 10 to focus their life towards an entrance exam. See, that's where the problem is, not in biology. People can happily do biology, maths, physics, chemistry all together. But in an attempt to squeeze time to prepare for an entrance exam where 5 marks can become a difference, people give up subjects that they were actually good at simply to get more marks. So we're going to have to think about how to take these people who never took CS, never took maths, and make them good at quantitative things. But on the other side, there is lots to do with being thoughtful about using AI in biology. And I think our cultural ability to introspect and think as opposed to be in a hurry, although that's changing with generations, is also a possible good thing we can bring towards AI and biology. But there is no shortcut except our departments need to come together. A department of biology today would not hire somebody without a degree in biology. A department of biology in America would easily hire a physicist without any problem whatsoever. So medical school in India will look for people with biology degrees. Again, we need to get over our terminology. The best exponents of AI in a field may have no formal degree that means anything to anyone. You need to look at what people do and their actual skills as opposed to going by degrees. A CS trained person from 10 years ago could be useless in AI in any applications, while a young kid who has done economics might turn out to be fantastic at doing some AI stuff in biology. We actually had one such student in Ashoka recently.
India's role evolving in global science diplomacy, especially around shared health challenges like climate linked diseases or AMR itself. How do you see it evolving?
I think we have to take a choice in the days ahead. There is clearly a direction one part of the world will go, in which you move away from global agreements and efforts. You move away from organizations like WHO, etc. And there'll be another part of the world that will believe in a shared vision of health, a shared vision of biology, a shared vision of cooperation. Now, India has friends on both sides. And what India decides might actually become something like a non-aligned movement from long time ago. So I think right this at the moment, we have interesting choices to make. What is the right choice seems like don't antagonize either side, work with everyone. How to do it is going to be like, walking on shells. And I think an interesting challenge lies ahead. That's the best I can say, because it's a very different world right now than what it was even a few years ago. So,
AI has been identified as a critical enabler in India's healthcare journey. So, how is government, you think, is ensuring that AI-driven solutions don't just remain as pilot projects, but actually reach the last mile population across India? We have several, like internet is there everywhere, but are we really is going to the grassroots level? Or I'm asking you, is this a question too early to to be asked?
One is the India AI mission. And as a disclosure, I sit on the committee for health AI. We have invited proposals ranging all the way from responsible AI to actual deployment solutions. Niti Aayog, even 2 years ago, ran a very nice thing looking at AI-based reduction of diabetic retinopathy. The person who ran it, Mona Duggal, is now the director of a new institute of ICMR called the ICMR Institute for National Institute of Digital Health Research. Well, there is a longer name, but I believe the final name will be this. And they are thinking about how to evaluate AI, how to validate AI. And I think the biggest challenge will be there. Foundational models of AI will become freely available, tuning them to local purposes, building our own foundation model side by side, but most importantly, validating them at scale, and then deploying them at scale, and then monitoring them at scale is going to be the big challenge. But India having become digitally transformed, where we can use our digital large-scale presence at every corner of the country to do this, I think is the best place in the world to try this out. Young companies are coming up that are working with National Digital Mission, Ayushman Bharat, to provide interesting solutions. Just met a few of them recently. In fact, in a few days from now, starting 25th, we will have the World Health Summit regional meeting at Bharat Mandapam. 150 sessions, 3 days, multiple in parallel. The idea is scaling. That's the theme of it. Taking forward India's G20 presidency. Because you have to scale health access. You have to use digital health. You have to think about AI. You have to think about responsible AI. And you have to build it for the world from India, because we are a rare, poorly developed country in some areas that is well developed in the area of IT, capable of building the solution. Many other countries like us with similar needs don't have that level of technological advancements. So here is where India builds not for itself, but for the world. But there will be challenges. We still need more ease of doing science. You may have seen newspaper articles about it over the last few days, where the government has asked Niti Aayog to come up with a paper on the ease of doing science. If we focus on that, I think most of the things will happen on its own.
But how practically this will be done is a question which
Yeah,
I have. Like,
sure. Let me give you a very concrete example. Uh, let's take a tool like diabetic retinopathy. It was already tested for deployment in villages and screening was done well. Problem was the upstream referral for somebody with retinopathy didn't exist. So that's an example of a good AI solution that didn't scale because it wasn't fully equipped. On the other hand, areas in Rajasthan which have CT scanners but no radiologists are using technology to quickly read scans. Some state governments are using AI-based chest X-ray AI systems to automatically screen for tuberculosis. That is scaling well. Because if that is done, then giving the treatment goes into the doc program, which is straightforward. So I think people who are from pure health implementation background, not from tech is great background, who have on-ground realities of where an answer coming from AI will lead to uptake and use, should get involved in deploying it. So in a recent Center of Excellence, the Ministry of Health was directly engaged with people who run the national programs to give on advice on what will be useful, what will not be useful. Similarly, there is a very large digital health program for diabetes and uh, hypertension management. They showed that when deployed at state level using digital health and some AI, it was able to bring down average blood pressures for people receiving those by about 5 mm Hg. That's actually a lot. So, but this combination of on-ground deployment people working with AI people is critical. Left to themselves, AI people will not accomplish that much.
but happening in certain pockets is the problem. Like, how do we collate this and bring it into?
The pockets is necessary. In pockets, you will generate the evidence before you scale. Just because you're convinced something is good doesn't mean you should scale it immediately. Go to a pocket, test it well, generate the evidence, publish the evidence, get it peer reviewed, get feedback, then scale. That's absolutely fine.
Collaboration between the tech giants like Google and local medtech startups signal for the future of public-private innovation in India's health space was my question. I think you covered it. You want to add on something?
But I would say not just the tech giants from outside, like Google, Microsoft. We are seeing simple funding by places like Gates Foundation to people in India who are doing phenomenally. I have met young companies who are built using India-built technology to help the Singapore government build a responsible AI platform. And I am seeing completely homegrown companies funded entirely by the Indian equity VC ecosystem that is now raising global money. So I think everything is happening in India together. And that's the reason I believe things will keep occurring. And many will, of course, not deliver. That's the nature of things. But enough have started that some will surely deliver.
Things starting up in the AI from the government side also. But do you think India currently lacks comprehensive regulations for AI in healthcare?
I think
Generally,
everybody,
also.
I think everybody lacks regulation for AI in healthcare
Yeah.
because AI, current modern generation, particularly large language models upwards,
Yeah.
LMMs or LLMs, depending on you work with only language or images as well,
Yeah.
is a specification less product. Now, when you have a specification less product, the only way you can use it is by large scale validation and evaluation. Now, large scale validation evaluation automatically will take time. So we will keep going through this cycle. I don't see a way out of it. Some things will work, some things won't. We'll keep trying.
But
And the
yeah.
efforts of the government in supporting these things will be good. Too much regulation will constrain it. What is much better is to specify the core principles, what type of data you must include before you can use it in India. You must have some Indian data on which you tested your AI. You must have some degree of understandability and transparency. You must have a way of evaluating the outcomes. You must have a way of knowing the ground truth. These kinds of things are there, and complete black boxes with no descriptions should be discouraged. But I would be careful to not overregulate the sector. It's a small nascent sector. Overregulation will kill it. You have to handle it gently. Some people always argue the reason the tech sector did very well in India is because the government never thought that it was going to be that important. They were more focused on manufacturing and big factories and things like this. So I think AI needs a sufficient balance. Lean, not too many rules, but balance that the interest of participants is protected.
I was about to ask the top three priorities in building a robust regulatory and ethical framework, but I think you've mentioned it.
Yeah.
Yeah. So, looking towards 2030, like 5 years down the line, what does a fully AI integrated healthcare system India look like? From like the patients walking in, everything is like automated to discharge, from the OPD to the discharge and the follow up, and how can we like this a balance of technological advancement with patient safety and public trust? How do you see it? Is it 5 years down the line all these things will happen, or is it too soon?
So there is a famous, slide meme that I show. It starts with Geoff Hinton, talking about radiologists becoming obsolete in few years in
Yeah, yeah.
2015. It has Elon Musk talking about self-driving cars in a few years. And the last part of it is radiologists driving themselves to work even today. So very similar to that, 2030 healthcare system will not look terribly different from the system we have today, except for 3, 4 things. One, the patient will have a lot more information at their disposal on their smartphones. Their ability to access the healthcare system easily without waiting in very long queues will get better. Their ability to see a remote doctor or just an AI for advice, which is just advice, it is not a medical consultation, for small problems at their own risk, right, will rise tremendously. Most of these things will work well. Inside the healthcare system, there will still be a human. That human will also be assisted with AI to make them more efficient and to allow them to make fewer errors and take care of things they may not have been able to take care of otherwise. Beyond that, nothing much will change. And as you come to the top end system of tertiary healthcare, of course, a huge amount will change in terms of new drugs discovered with AI, in terms of precision wellness, in terms of lifestyle advices, people using AI even before they become sick, because they can pay for this advice, because they can use CGMs. The biggest disruptions will come there. Another place I expect to see a huge disruption will be AI in education. Training of healthcare workers. AI will become common.
Thanks, Lord.